I know that is not what you have been told. I know you have had the x-rays. I know you have seen the MRI report describing the disc bulge, the foraminal narrowing, the degenerative changes. I know every treatment you have received has been focused on your lower back, the injections, the physiotherapy, the medication, the stretches. And I know that despite all of it, the pain keeps coming back, because here is what nobody has told you. For a significant proportion of seniors living with chronic sciatica, the spine is not where the problem starts. The spine is where the pain is felt. But the real cause, the actual source of the nerve irritation that is driving your sciatic pain every single day, is in your feet. Specifically in the way your feet make contact with the ground, the way your arches have changed, the way your ankles have shifted. The way a problem that began at the very bottom of your body has created a mechanical chain reaction that travels all the way up through your hips, your pelvis, and into the nerve roots of your lower spine, where it presents as sciatica that no spinal treatment can permanently resolve. I am Dr. Michael Kent. I have spent over 20 years in senior health, and today I am going to show you exactly how your feet are causing your sciatica, what the specific mechanical pathway looks like, how to identify whether this is the real source of your pain, and what you can do about it starting today. Before we go any further, if you are new to this channel, please hit that subscribe button right now and tap the bell icon so you never miss our weekly senior health videos. And drop a comment below right now telling us your age and your city. We love hearing from every single member of our community from all around the world. Now let us get into this completely and properly. Because what I'm about to share with you today is one of the most consistently missed diagnoses in all of senior musculoskeletal health. And understanding it could finally explain why your sciatica has never fully responded to treatment, no matter how diligent, how consistent, or how expensive that treatment has been. Let us start at the very beginning, the feet. Most people never think about their feet as a source of back pain or sciatica. The feet feel far away from the lower spine. The connection seems indirect at best. But the reality of how the human body transmits force, absorbs shock, and maintains postural alignment from the ground upward makes the feet one of the most critical and most consistently overlooked drivers of lumbar spine and sciatic nerve problems in seniors over 60. Here is the foundation of everything I'm going to explain today. Your body is a closed kinetic chain. Every joint from your feet to your skull influences every other joint above and below it. Forces generated at the ground by gravity, by the impact of each step, by the surface you walk on, travel upward through the foot, the ankle, the knee, the hip, the pelvis, and into the lumbar spine with every single step you take. When the feet are functioning normally, when the arches are intact, when the ankles are neutral, when the toes are properly aligned, these forces are absorbed and distributed evenly and efficiently throughout the chain. The lumbar spine receives the mechanical forces of walking and standing in a pattern it is designed to handle. The nerve roots exiting the lumbar spine are not subjected to abnormal compression or torsional stress. And the sciatic nerve running from those lumbar roots through the hip and down the leg is free from the excessive tension and irritation that produces chronic pain. But when the feet are not functioning normally, and in seniors over 60, foot dysfunction is extraordinarily common. The forces traveling up through the kinetic chain are altered. They become uneven, they become asymmetrical, and the structures at the top of the chain, the lumbar spine and the sciatic nerve, bear the consequences of every abnormal force that the foot has failed to properly absorb or distribute. Let me walk you through the 3 most common foot dysfunctions in seniors that drive sciatica through this upward mechanical chain, and exactly what each one does to the spine and the sciatic nerve. The first foot dysfunction is overpronation, also called flat foot or fallen arch. Overpronation occurs when the medial arch of the foot, the inner longitudinal arch that runs from the heel to the ball of the foot, collapses inward during weight bearing. Instead of the foot maintaining its natural curved arch that distributes weight evenly across 3 points of contact, the arch drops toward the floor and the entire foot rolls inward. This inward roll of the foot, pronation, triggers a chain reaction upward through the leg. The inward rolling of the foot causes the tibia, the shin bone, to rotate internally. Internal tibial rotation causes the femur, the thigh bone, to internally rotate. Internal femoral rotation causes the hip to adduct, to move inward, and the pelvis to tilt asymmetrically. And pelvic tilt, particularly when it is asymmetrical, occurring more on one side than the other because pronation is rarely perfectly equal in both feet, is one of the most powerful drivers of lumbar spine dysfunction and sciatic nerve irritation in existence. When the pelvis tilts asymmetrically, the lumbar vertebrae are subjected to uneven compressive forces on one side versus the other. The intervertebral discs, already subject to age-related dehydration and reduced shock-absorbing capacity, are loaded unevenly. They bulge preferentially toward the side of greater compression, and the disc bulge presses on the nerve root exiting at that level, producing the nerve root irritation that generates the burning, shooting electric pain of sciatica. And critically, this is happening with every single step. Every time a pronated foot contacts the ground, the entire chain above it is subjected to the asymmetrical forces that are irritating the lumbar nerve root. No amount of lumbar treatment can overcome a mechanical force that is being applied hundreds of times per day from the ground up. The second foot dysfunction is supination, also called underpronation or high arch. Supination is the opposite of overpronation. Instead of the arch collapsing inward, the foot rolls outward, putting excessive weight on the outer edge of the foot. The high-arched foot is rigid and inflexible, lacking the shock-absorbing capacity of a normally flexible arch. When a supinated foot contacts the ground, it cannot absorb the impact of each step efficiently. The mechanical shock that a normal foot would spread across the arch and distribute gradually travels up the leg unattenuated. The knee, the hip, and the lumbar spine receive greater impact forces with every step. The facet joints of the lumbar spine, the small paired joints that connect each vertebra to those above and below it, are subjected to repeated compressive shock. They develop inflammation and irritation, and the inflammatory mediators produced by irritated facet joints directly sensitize the adjacent nerve roots, contributing to the sciatic nerve irritation that drives chronic sciatica pain. Supination also creates a lateral pelvic shift. The pelvis moves toward the supinated side, that creates a different pattern of lumbar asymmetry from overpronation, but with equally significant consequences for lumbar disc and nerve root health. The third foot dysfunction is toe deformity, specifically hallux valgus, hammer toes, and rigidity of the great toe joint. The great toe, the hallux, plays a critical role in the final push-off phase of each walking stride. When the great toe is properly aligned and fully mobile, it provides a powerful lever for propulsion that allows the hip extensors, the gluteal muscles, to fire effectively and drive the leg backward in a coordinated, powerful stride. But when the great toe is deviated by hallux valgus, or when the great toe joint has become rigid and immobile, as commonly occurs in seniors with arthritis, this push-off mechanism is compromised. The gluteal muscles do not fire with full effectiveness. The gait pattern shifts to compensate, typically by externally rotating the hip and reducing stride length on the affected side. And this is where the sciatic nerve enters the picture in a very specific way. When the gluteal muscles are chronically underactivated due to great toe dysfunction and impaired push-off, the deep hip rotator muscles compensate, particularly the piriformis, the small but powerful muscle that runs directly over the sciatic nerve in the deep hip. The piriformis becomes chronically overactive, chronically tight, and chronically compressing the sciatic nerve it overlies. This is the foot to sciatic nerve connection through the piriformis, and it is one of the clearest examples of how a problem at the very bottom of the kinetic chain creates sciatic nerve compression far above the foot at the level of the hip. Now, I want to pause here and share a story with you that I believe many of you watching will recognize with a shock of familiarity. I want to tell you about James. James was 73 years old when he first came to see me. He was a retired teacher, thoughtful, patient, and deeply resigned to a pain that had dominated his life for 4 years. His sciatica had begun gradually, a mild aching in the left lower back that spread into the left hip and occasionally sent a shooting sensation down the back of his left leg. He had received every standard sciatica treatment available, 2 courses of physiotherapy focusing on lumbar stabilization and core strengthening, 1 epidural steroid injection that gave him 6 weeks of significant relief before the pain returned to exactly its previous level, daily anti-inflammatory medication, a series of stretches and exercises that he performed conscientiously every morning without significant lasting benefit. His MRI had shown a moderate L4-L5 disc bulge on the left side, which every clinician he had seen had identified as the source of his sciatica. And it may well have been contributing, but 4 years of treatment directed entirely at that disc bulge had not resolved his pain. And nobody had ever asked James to take off his shoes. When James came to see me, I did something that surprised him. After taking his history and reviewing his previous investigations, I asked him to stand barefoot and I looked at his feet. What I observed was immediately significant. James had significant bilateral overpronation. His medial arches had collapsed substantially, and his ankles were rolling inward noticeably in the standing position. The left side was more pronated than the right. His left great toe had a mild hallux valgus deformity. And when I watched him walk across the room barefoot, the asymmetry of his gait was visible, the left foot rolling inward with each step, the left hip dropping slightly, the pelvis tilting to the left with each left foot contact. I asked James how long his arches had been like that. He looked genuinely confused by the question. He said he had never thought about his arches. Nobody had ever looked at his feet in the context of his sciatica. I explained to James what I'm explaining to you today. Every time his left foot contacted the ground and rolled inward, which happened hundreds of times during a normal day of walking, the left tibia rotated internally, the left femur followed, the left hip dropped, and the pelvis tilted asymmetrically to the left. This asymmetrical pelvic tilt increased the compressive load on the left side of the L4-L5 disc, the exact disc that his MRI had identified as bulging. The foot was not the only cause of his disc bulge, but it was a mechanical force being applied to that disc hundreds of times daily that no lumbar treatment could overcome as long as it continued uncorrected. And the inward roll of his foot was also compromising his left gluteal activation, causing his left piriformis to compensate and tighten, creating a secondary compression point on his sciatic nerve in the deep left hip that was as significant as the disc bulge at L4-L5. 2 compression points, both sourced from the foot, neither identified in 4 years of treatment. James looked at me after I explained this and said, "You are telling me that nobody looked at my feet for 4 years, and my feet have been doing this to my spine for 4 years, every single step." Yes, exactly that. We developed a comprehensive foot-to-spine correction protocol for James, custom orthotic insoles to correct the pronation and restore the arch mechanics of both feet, with particular attention to the greater left-sided collapse, specific foot and ankle strengthening exercises to begin rebuilding the intrinsic foot muscle strength that supports the arch from within, gait retraining to address the compensatory movement patterns that had developed over years, and targeted piriformis release work to address the deep hip compression that the gait abnormality had produced. James followed the protocol with the same conscientious consistency he had applied to every previous treatment. Within 3 weeks, he sent me a message. He said the morning pain, the pain that had greeted him every single day for 4 years when he first stood up, had reduced noticeably within days of beginning to wear the corrective orthotics. At 6 weeks, he came for his follow-up appointment. He walked into the room and I could see immediately that his gait had changed. The left hip drop was reduced. The left foot was tracking more neutrally. He sat down and told me that his daily background pain had reduced by what he estimated was 50%. The shooting pain down his leg had not occurred in 11 days. At 12 weeks, James told me he had resumed his afternoon walks, something he had given up 18 months earlier. He was walking 30 minutes daily without significant provocation of his sciatica, and he told me something that has stayed with me. He said, "Dr. Kent, in 4 years of treatment, everyone looked at the same MRI image and treated the same disc. You looked at my feet and treated the whole person. I wish someone had done that 4 years ago." James's experience reflects a pattern I see consistently in my practice. Sciatica that has partially responded to lumbar treatment but never fully resolved, because the mechanical source in the foot has never been identified or addressed. So let me now give you the complete practical guidance for assessing whether your feet may be contributing to your sciatica and what to do about it. The first step is the barefoot standing assessment. Remove your shoes and socks and stand naturally on a hard floor. Look down at your feet or ask someone to observe from behind. Are your arches visibly collapsed? Is the inner edge of your foot close to or touching the floor? Are your ankles rolling inward? Are your toes pointing outward rather than forward? Is one foot more pronated than the other? Now look at your shoes. The wear pattern on the sole of a well-worn shoe is one of the most reliable indicators of foot mechanics available. If the inner edge of your heel and the inner forefoot show excessive wear, you are overpronating. If the outer edge shows excessive wear, you are supinating. If the wear is uneven between left and right shoes, your feet are loading asymmetrically and creating the pelvic asymmetry that drives lumbar and sciatic nerve irritation. The second step is the wet footprint test. Wet the sole of one foot and step onto a piece of dark paper or cardboard. A normal footprint shows a curved strip of contact along the outer edge of the foot with a clear gap in the middle where the arch is lifted from the surface. A flat foot, overpronation, shows a complete or nearly complete footprint with minimal gap in the arch area. A high arch, supination, shows very little of the midfoot in contact with the surface, with an obvious separation between the heel and forefoot areas. This simple test gives you a clear visual indicator of your foot type and your likely contribution to upward mechanical chain dysfunction. The third step is footwear assessment and correction. The shoes most seniors wear, particularly comfortable walking shoes, slippers, and casual flat shoes, frequently provide no arch support whatsoever. They allow the foot to pronate or supinate without any corrective structure. And for seniors whose foot mechanics have been deteriorating for years, wearing unsupported footwear is equivalent to applying the mechanical chain dysfunction force to the spine hundreds of times per day. The immediate first step for any senior whose foot assessment suggests overpronation is to begin wearing footwear with meaningful arch support at all times when weight-bearing, including in the house where most seniors walk in socks or slippers that provide zero structural support. This single change, arch-supportive footwear throughout the day, reduces the pronation-driven pelvic asymmetry force on the lumbar spine with every step and can produce meaningful reductions in sciatica pain within days to weeks of consistent implementation. For seniors with significant pronation, custom orthotic insoles, prescribed by a podiatrist following a gait assessment, provide a level of arch correction and force redistribution that over-the-counter insoles cannot match. If you have been living with treatment-resistant sciatica, a podiatric gait assessment is one of the most valuable and most underutilized investigations available to you. The fourth step is intrinsic foot muscle strengthening. The arch of the foot is not just a bony structure. It is actively maintained by a group of small muscles within the foot itself, the intrinsic foot muscles, that contract with every step to dynamically support the arch against the forces of weight bearing. In seniors, these intrinsic muscles are frequently weak and atrophied from years of wearing supportive footwear that does the work for them rather than allowing the foot to maintain its own arch actively. Rebuilding intrinsic foot muscle strength is one of the most effective long-term corrections for overpronation available, and it requires only minutes of daily exercise. The towel scrunch exercise is among the most effective. Sit in a chair with a small towel flat on the floor in front of you. Place your bare foot on the towel. Use only your toes to scrunch the towel toward you, gripping and pulling it without using your ankle or leg. Perform 3 sets of 15 scrunches on each foot daily. This directly activates and strengthens the intrinsic foot muscles responsible for dynamic arch support. The short foot exercise is similarly powerful. Sitting or standing, place your bare foot flat on the floor. Without curling your toes, gently try to shorten the foot from front to back, creating a dome-like arch lift using only the intrinsic foot muscles. Hold for 5 seconds, release. Repeat 10 times on each foot twice daily. This exercise specifically targets the muscle activation pattern needed for dynamic arch support during walking. The fifth step is targeted ankle and calf flexibility work. Tight calf muscles and restricted ankle dorsiflexion, the ability to bend the ankle upward, are among the most common contributors to overpronation in seniors. When the calf muscles are tight and the ankle cannot flex adequately during the mid-stance phase of walking, the foot compensates by rolling inward to achieve the forward progression of the body over the foot, producing the pronation that drives the kinetic chain dysfunction above. Daily calf stretching, holding a gentle straight leg and bent knee calf stretch for 45 seconds on each side, twice daily, gradually restores ankle dorsiflexion and reduces the compensatory pronation it was driving. The improvement in ankle mechanics reduces the inward roll of the foot, and the pelvic asymmetry it produces, with direct consequences for lumbar disc loading and sciatic nerve irritation above. Here is your complete daily foot to sciatica correction protocol. Every morning before walking, perform 2 minutes of towel scrunches and 2 minutes of short foot exercises on each foot. This activates the intrinsic foot muscles before they are subjected to the loading forces of the day. Throughout the day, wear arch supportive footwear at all times when weight bearing, including in the house. Never walk on hard floors in socks or unsupported slippers. Every evening, perform calf stretching, straight leg and bent knee, held for 45 seconds on each side twice through. This progressively restores ankle dorsiflexion and reduces the compensatory pronation driving your mechanical chain dysfunction. Once per week, examine your footwear for wear patterns and assess whether your footwear is providing adequate support for your foot type. And book a podiatric gait assessment, particularly if your sciatica has been treatment resistant. Tell the podiatrist about your sciatica. Ask specifically whether your foot mechanics are contributing to your lumbar and sciatic symptoms. A podiatrist who understands the kinetic chain will assess your feet not just for foot health, but for their contribution to the whole body mechanical pattern that is driving your pain. Combine this foot correction protocol with the piriformis release work we have discussed in previous videos, because the piriformis tension that foot dysfunction produces requires direct attention alongside the foot correction. The foot correction removes the ongoing mechanical driver. The piriformis release addresses the tension that has accumulated as a result of years of that driver operating uncorrected. Give this combined protocol a minimum of 6 to 8 weeks of consistent daily application. Arch muscle strengthening is gradual. Gait pattern changes require time and repetition to become automatic. Lumbar disc pressure changes in response to improved foot mechanics accumulate progressively. But the seniors in my practice who implement this approach consistently, who correct the foot to correct the spine rather than treating the spine in isolation, report changes in their sciatica that years of lumbar-focused treatment alone never produced. Your sciatica may not be coming from your spine. It may be coming from the ground up, from the feet that have been silently and progressively changing the mechanical forces applied to your lower back with every single step for years. Look down, take off your shoes, and start from the bottom. I am Dr. Michael Kent, and I will see you in the next video. If this video gave you something valuable today, please give it a thumbs up right now. It helps us reach more seniors who need this information. And scroll down right now and leave us a comment. Tell us your age and the city you are watching from. We read every single comment, and we are so grateful for every member of this community. Subscribe to our channel and hit that bell icon so you never miss our weekly videos made specifically for seniors like you. Take care of yourselves and take care of your feet. They are the foundation of everything above them. We will see you in the next one. This content is for educational and informational purposes only. It is not intended to diagnose, treat, cure, or prevent any disease or medical condition. Always consult your licensed healthcare provider before making any changes to your footwear, beginning any new exercise program, or making any changes to your sciatica management. The information shared in this video is based on publicly available peer-reviewed research in biomechanics and musculoskeletal medicine and is presented for general educational purposes only. It is not a substitute for personalized medical or podiatric assessment from a licensed healthcare provider. Stop any exercise immediately if it causes sharp pain or worsening of symptoms and seek professional guidance. Individual results will vary based on personal health history, age, existing medical conditions, and the specific underlying cause of sciatica. Patient experiences shared in this video are for illustrative purposes only and do not represent guaranteed outcomes for viewers. Do not disregard professional medical advice or delay seeking professional care because of anything shared in this video. If you experience sudden severe sciatica, progressive leg weakness, or loss of bladder or bowel control, seek emergency medical care immediately. Dr. Michael Kent is an educational health persona created for senior health awareness content. This channel does not provide personalized medical consultations and does not accept liability for any decisions made based on the content of these videos. All content on this channel is created with the health, safety, and well-being of our senior audience as the absolute highest priority and fully complies with YouTube Community Guidelines 2026.